keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
So 2 manuscripts in a forthcoming issue of the JACC Imaging have highlighted the intermediate term prognostic implications of defining the extent of coronary artery disease by CT angiography. One, in patients presenting to the emergency room with chest pain and no obvious evidence of acute event, and other in defining the unprotected territories in patients after surgical coronary revascularization. These 2 manuscripts, one from Trong et al. From Mass General Hospital and the other one from Dr. Chow from Ottawa Heart Institute, respectively, have added to the growing literature about the prognostic importance of CT imaging. These 2 manuscripts have drawn an excellent editorial from Dr. Schoenhagen, Dr. Hakamovich, and Dr. Achenbach, wherein the editorialists, in addition to these 2 manuscripts, also discuss extensively the meta-analysis of almost 10,000 patients presented by Villainous et al., published very recently in the journal JACC. I welcome Dr. Schoenhagen of the Cleveland Clinic for an interview from JACC San Diego office. Welcome, Dr. Schoenhagen. Would you please give me a 2-line description of these 2 papers and that of the meta-analysis by Villainous et al.?
Yeah, let me begin with the paper by Villainous from the Walter Reed Medical Center in Washington, which is a meta-analysis of about 18 trials and about 10,000 patients, looking at a combined measure of plaque burden, including luminal stenosis and atherosclerotic plaque in the coronary arteries, and its prognostic outcome for major coronary cardiovascular events. The paper by Villainous et al. Shows the prognostic value of CT angiography in addition to identifying hemodynamic significant lesions. The 2 papers, upcoming papers in JACC Imaging, extend this data by looking at specific subgroups. The paper by Schlett et al. Is a sub-analysis from the ROMICAT trial, patients presenting to the emergency room with chest pain, and shows prognostic value of CT angiography in this setting. And the paper by Chow and al. Shows prognostic value of CT angiography in patients who had prior coronary bypass surgery, where the authors differentiate between protected and unprotected myocardial territories based on presence or absence of significant stenosis in the supplying native vessel and the bypass grafts.
And what about the comparative value of various imaging and non-imaging diagnostic strategies?
As you know, over the last decade, since coronary angiography has been introduced into cardiac imaging and particular coronary imaging, we have first assessed diagnostic accuracy in comparison to coronary angiography for luminal stenosis and intravascular ultrasound for plaque burden. Then the data in groups all over the world has demonstrated an additional prognostic value of looking at luminal stenosis and plaque burden prognostic value for cardiovascular events over the next couple of years. And I think the next step is now to compare different imaging modalities, or more broadly, different diagnostic strategies to decide in which clinical situation a specific patient would benefit from one diagnostic or one imaging approach versus the other. And that is, of course, described under the term of comparative effectiveness research. And I think that is still where there is a lack of data describing the relative significance of diagnostic approaches.
And what do you think is the advantage of looking at the luminal compromise and at the same time that of the plaque composition also, which is something which is very unique that we get from the CT angiography as compared to all other diagnostic strategies?
I think the advantage of CT angiography is that it allows to look at luminal narrowing or absence of luminal narrowing, but also presence of atherosclerotic plaque, both calcified plaque as has been described with coronary calcium scoring and non-calcified plaque. Therefore, combining the information one could obtain with coronary angiography and intravascular ultrasound, and obviously both the presence of significant stenosis, but also the presence of atherosclerotic plaque in the absence of significant stenosis has prognostic value in a graded fashion. The papers we are discussing upcoming in JACC cardiovascular imaging, and also the recently published study from Walter Reed Army Medical Center actually shows that the risk in patients that have no luminal stenosis but also no evidence of atherosclerotic plaque have a very low risk of future events, similar to a background population, less than 1%. That patients with significant stenosis, defined as more than 50% luminal narrowing, have an event rate of about almost 10%, but that patients that have no significant stenosis but presence of atherosclerotic plaque would have an intermediate risk of cardiovascular events in the range of perhaps 2 or 3%. And of course, that is similar to data that comes from intravascular ultrasound, and is data which is still to some extent incompletely understood, because with intravascular ultrasound and also with CT you can look at plaque burden but also plaque composition, and that is of course an area of significant research to understand not only plaque burden but also plaque composition and their relationship.
Thank you, Dr. Schoenhagen, for your excellent editorial for JACC Imaging and also taking time to come out for this interview. Thank you.